Okay, vitamin B12 deficiency can present with macrocytic anemia. You can have neurological manifestations, paresthesias, or subacute combined degeneration. You tend to see a lot of these cases in older individuals. They may have some pernicious anemia involved, and they will have antibody-mediated destruction of intrinsic factor. They also have antibody-mediated destruction of the gastric parietal cells. When you have this constant targeting of the gastric parietal cells, you eventually will get atrophy of the acid peptin producing parts of the stomach. And over time, because of this, you get atrophy of the gastric mucosa and it undergoes some type of intestinal metaplasia. With metaplasia, you have an increased risk for gastric cancer. Sometimes you may be confused if the patient may have some type of acute myeloid leukemia because this can also lead to myelofibrosis and it can cause symptomatic anemia. But remember to always look at the MCV and look for macrocytosis. This is a lot less common in AML, and if the patient has any type of peripheral neuropathy at all, you should definitely suspect vitamin B12 deficiency first. A quick recap about how vitamin B12 is absorbed into our bodies. There are 4 parts to the absorption of vitamin B12. Number 1 is the salivary glands, which have R protein. Number 2 is the stomach, which has intrinsic factor and gastric acid. Number 3 is the pancreas, which includes proteases. And lastly, the ileum is important for absorption. Any damages to these structures, you have impaired intake. But the most common cause, like I mentioned earlier, is pernicious anemia when you have the antibody-mediated destruction of intrinsic factor.